There we go. All right. So now we're going to talk about the brainstem, the part of the brain that kind of pops off the inferior region there to the cerebrum and all that. So think of this as the connection area here. You'll notice that this region of the brain connects to the other three regions of the brain. And in the brainstem, you're going to see sensory and motor tracts. Sensory tracts are also known as ascending tracts, meaning sensory input information comes out from the periphery, like from your joints, your muscles, your skin, and it goes into the spinal cord and up into your brain. So it's ascending, it's going up. So that's going to be sensory. Motor, and remember we learned that the primary motor cortex, which is the precentral gyrus, right? That's located in the frontal lobe, right? That's where you initiate whatever motor action that you're going to do, and that motor action then is going to then descend or go down into the spinal cord and out to the effectors, muscles or glands, all right? But if we're talking about the primary motor cortex, we're going to be referring to, all right, specifically skeletal muscles. And so that's the descending tract is a motor tract. You'll also see a whole list of things up here. Contains autonomic nuclei, right? We know what nuclei are. Those are going to be those clusters of cell bodies, nuclei of cranial nerves, and reflex centers. So a lot of important structures, right, for a lot of our systems like your respiratory, cardiovascular. We're going to talk about a lot of these. A lot of these control centers are located in the brainstem. So there's three parts to your brainstem. You have the midbrain, that's on the top, that's the superior most portion. Then you have the pons, which is in the middle. And then you have the inferior most portion called the medulla oblongata. A lot of stuff in the medulla oblongata, and it's relatively a small region there. So you can see here, all right, an anterior view of the brainstem. So midbrain is up here, Pons is right in the middle, and then the medulla oblongata is located down here on the inferior portion. And eventually the medulla oblongata transitions, all right, and it connects to the spinal cord. So the inferior part of the medulla oblongata is really hard for folks to discern or differentiate between from the cervical spine because they're so very similar there. Here you can see a nice posterior lateral view from the side. To me, I don't know, I always thought it looks like an ice cream cone, okay? But this is showing you, right, you got the midbrain down here with your thalamus, right? You remember what the thalamus is, or the thalami, because you have the right and left thalamus, right? That is going to be the relay station, if you all recall, right? All sensory input information goes to and through the thalamus on its way to its specific area of the cerebral cortex. There's only one sense that does not go to the thalamus. Do y'all remember which one? Smell. Yeah, olfaction. Good, good. All right, so let's start off with the midbrain. Right? That is the superior most portion. And I'm going to kind of go back and forth on some of these so you kind of see what I'm discussing here. All right, so the first structure there are called the cerebral peduncles there. And these are going to be, right, a region that has motor output information traveling through it. So I'm going to come right back to this. I'll show you. Here you can see there's this cerebral peduncle. I'll show you on the anterior view. It's like these striated structures here. That's the cerebral peduncles there. And that's where a lot of motor output information is going to travel through, down, right? Specifically, voluntary motor. Okay, so skeletal muscle commands are going to travel through that region. Now, all three parts of the brainstem connect to your cerebellum, the small little brain that sits on the back. And so each part, right, each part of the brainstem has its connection, and we call those cerebellar peduncles. So since the midbrain's on top, we call the peduncles that extend off of the midbrain the superior cerebellar peduncles. And that essentially is just where the midbrain connects to the cerebellum. We'll talk about the cerebellum and what its functions are, but it's the part of your brain that likes to fine tune a lot of motor movements. So it would make sense that there should be a connection there. Then we'll talk more about this next structure when we do chapter 14, but the medial lemniscus is going to have ascending axons, which means sensory axons, right? And so they're going to be located, all right, and we'll talk about the medial lemniscus and what sensory information that it carries there. But this is also going to be located in the midbrain. Now, the next part, very important structure, because I mentioned Parkinson's last class. And so Parkinson's is a condition in which you have too little dopamine, which is a neurotransmitter, being produced. And so what we have found that there's an area in the midbrain called the substantia nigra, and this is this area of dark colored cells that produce dopamine. And we've discovered that dopamine, when these cells aren't producing enough dopamine, people will get Parkinson's syndrome there, right? So keep that in mind. They are going to have, all right, a dark appearance, but they're producing that neurotransmitter called dopamine. And when this area starts to degenerate, you will get Parkinson's disease there. Right, so these people will have like a stiff kind of posture. They'll have what we call resting tremors, which when they're just sitting around, not doing anything specific. Their hands can shake, all right? It gets worse. Their whole body, not whole body, but larger portions of their body will start to shake as the disease progresses on, right? They have a very stiff gait, right? They have jerky movements, right? There's a whole bunch. And then, you know, in the latter stages, they can start to have emotional issues that are happening, right? So come a long way with Parkinson's, but we still have a long way to go. All right, so that's the midbrain there. Moving on, we have the tegmentum, the cerebral aqueduct, which we already talked about when we were labeling the ventricles there. And then we have this other structure called the tectum. So the tegmentum here, and we'll talk a little bit more about this as we in the chapter here, but this is where, all right, postural motor control is going to be involved. And so you have these two structures here called the red nuclei and the reticular formation. Reticular formation has a lot to do with muscle tone. And we'll see here, right, during certain awake periods, right, levels of alertness, right, with the reticular formation, we're going to see how certain parts of the reticular formation will be involved in motor control, like muscle tone, and then cognitive conscious alertness. Like, for example, I'd like to think that all of us here are relatively fully alert right now, but we're less alert when we first wake up in the morning, all right? And we're even less alert when we're sleeping. And so the reticular formation, we'll talk about that in a little bit about what role it plays. Okay, cerebral aqueduct, this is that long canal-like or tube-like structure that connects the third and fourth ventricle in the brainstem there. Ocular motor and trochlear cranial nerves, their nuclei are located here in the midbrain. I'll show you a transverse section here, right? But pretty much you're going to see an extension of the nerves for both cranial nerve 3 and 4 coming out of the midbrain. And as we move further down, through the brainstem, you'll see several other cranial nerves that are coming off of the different regions and parts of the brainstem there. And then the tectum. When we were labeling in lab these ball-like structures of the midbrain, they sit on the back. I'll actually just show you a picture. It's easier to just show it to you. You can see right here, these 4 bumps right here, 1, 2, 3, and 4, right? The top 2 bumps are called the superior colliculi. The bottom 2 bumps are called the inferior colliculi. But when we look at all 4 of them, they form this structure called the tectal plate, also known as the tectum. The top 2, the superior colliculi, have to do with visual reflexes, like if you're watching a tennis match, for example, and the ball's getting volleyed back and forth, so your eyes just follow the ball back and forth. That information goes through the superior colliculi. It keeps your eyes moving at the same together, not one going one way and the other one going the other way, for example. The inferior colliculi has to do with auditory reflexes. So, for example, you're sitting in the library and someone calls your name and they're standing off to your right, that information that goes through the auditory reflex of you turning your head to see where that stimulus was coming from, that information is processed through the inferior colliculi there. Right, so that is all going to be part of the tectum there. Okay, so superior colliculi, visual reflexes and tracking, inferior colliculi, auditory reflexes. How I remembered it is in most people, okay, your eyes are going to be a little bit higher than your ears. However you want to know which is which, but that's how I remembered it. So here you can see, right, here's our nice midbrain section right through here. And you can see both the superior colliculi and the inferior colliculi on the posterior portion. So here is our transverse section. It really stands out. You can see the substantia nigra loaded with melanin, which gives the cells that dark color, but that's where the dopamine is supposed to be produced. And folks that are deficient or have Parkinson's, there's degeneration of the cells in the substantia nigra that produce the dopamine. And so they'll have those symptoms there. You'll also notice here, you've got the red nuclei. It's hard to really miss that, okay? Then you can see the nuclei for the ocular motor nerve, and then we'll talk a little bit more about it when we get into chapter 14, but you can see the medial lemniscus. It's this white region here, right next to the substantia nigra. And it's white because it's myelinated, okay? Cerebral aqueduct, some other areas here too. But right up here, the cerebral peduncle here, there's where you're going to see that connection between, not the cerebral peduncle. This is going to be loaded with somatic motor neurons. Somatic motor neurons. All right, let's move on to the second part of the brainstem, and that's the pons. Pons means bridge, and that's what it does. It bridges, all right, between the midbrain and the medulla oblongata. So what we're going to see here in the pons, we're going to see more sensory tracks, more motor tracks, right? And then we're going to see the connection between the pons and the cerebellum, right? So we have our middle cerebellar peduncle there. And then I think I was talking to you about this, about the pontine respiratory center. So you have breathing control centers in your brainstem. Your primary breathing control center is in the medulla oblongata. The pontine respiratory center, that is going to assist in breathing. If you damage it, it's not like you won't be able to breathe. You can still breathe. But what it does is it helps to regulate a nice smooth transition between inspiration, which is taking a breath in, and expiration, which is exhaling and blowing a breath out. So it helps with those skeletal muscles that help to make that a smooth transition. If you damage that area, you'll have like a ratcheted type of breathing, and it looks like you're almost struggling to breathe, but not really. We'll also see the superior olivary nuclei. That has to do, we'll talk more about that in chapter 16, but that's for sound localization. Again, right, when you do hear something, right, how do I know if it's to the left of me, if it's to the right of me, if it's above me, if it's below me, right? The superior olivary nuclei will assist in that. And then you'll notice some of our cranial nerves here, cranial nerve 5, which is trigeminal, cranial nerve 6, right, which is abducens, cranial nerve 7, which is facial, and then cranial nerve 8, right, which is vestibular cochlear nerves. All of the nuclei are located, right, in the pons. Okay, that's where those cranial nerves originate from. Okay, so cranial nerve 5 through 8, trigeminal, abducens, facial, and vestibular cochlear. So here you can see that's that bulging area here of the brainstem. That's the pons there. And so you can see right over here, posterior to that, that's where the cerebellum is. So you're going to have your middle cerebellar peduncles that attach the pons to, right, the brainstem, to the cerebellum there. And you can see in our nice, on our transverse cut here, several of the nuclei for some of our cranial nerves, and you'll start to see the fourth ventricle poking through there. All right. I hate to say it, but the pons is not the most exciting. Now we get to the exciting part, the medulla oblongata. I'm going to show you this slide here and look at the next slide. Look at all this stuff that's in the medulla oblongata, right? Medulla oblongata is the bottom portion, the inferior-most portion of the brainstem. And so, again, we're going to see areas in this region having both motor and sensory tracts, essentially connecting the spinal cord to your cerebrum, to the brain there. So you'll notice on the front portion, the structure called the pyramids. I'll show you, I'll come right back. Right here you can see one pyramid and the other. They're right here on the front. Right, those are referred to as the pyramids. Right, the pyramids carry, we'll talk about this tract next chapter, the cortical spinal tract. This is going to be, all right, that motor tract that I was telling you about that controls your skeletal muscles. And I said that the left side of your brain controls the right side of your body and vice versa. So that means that those neurons have to cross over somewhere. And there's two places that they can cross over. One is in the spinal cord, and this is the other place. In fact, most of the neurons will cross over here in the pyramids, right? Specifically at this structure in the pyramids, what we call the decussation of the pyramids. And you'll see it. I'll show you back on this slide here. You zoom in. That's what you're seeing here. You can see how these motor tracts are descending and then they cross over. Right, and where they cross over, it's almost like a crisscross pattern. You can see here are those motor neurons, and they're descending and they're crossing to the other side. Here's some of those motor neurons, and they're crossing over, going to the other side. And so that is where you're going to see a majority of those motor neurons are going to cross over what we call the decussation of the pyramids there. That's what decussation means, right? It means to cross over, crisscross there. So that's how the right side of your brain controls the left side of your body. So just lateral, on either side of the pyramids, we have these structures called olives. And again, they look like more bulges here, right? And so they're going to also play a role, right, in motor function, except they're going to play a role in what we call proprioception. Proprioception is the sensory input information that you receive from your muscles and joints that tell you what those joints are doing. So for example, I'm sitting here and my knees are bent. In fact, I'd like to think that most everybody's knees are bent sitting in these chairs. Okay. Now, I don't even have to look down to know that my knees are bent, right? But my brain is telling, or excuse me, the receptors around your knees are sending sensory input information to your brain to tell you that your knees are bent. Or another way you can look at it is if I were to just have my eyes closed and someone were to come over and grab my shirt and then just lift my arm up. Okay, I'm totally relaxed. But if they're grabbing my shirt and lifting my arm up, right, I know, all right, that my arm is, say, about 90 degrees right now. I mean, I know I'm doing it, but say someone was lifting that up. The receptors in my glenohumeral joint are shooting information to my brain that's telling my brain, hey, you're at 90 degrees. Now you're at 45 degrees. Now you're at 120 degrees. It's telling my brain that, right, through, okay, what we call proprioceptive. We'll get into more details about that concept, but it's just really important. And your cerebellum plays a huge role in proprioception. Remember, it's the fine-tuning region of your brain. Helps to fine-tune certain motor movements there. As you're writing, right, as you're doing things that require manual dexterity, your cerebellum plays a role in that. And then, of course, we have the inferior-most portion of your brainstem that's going to connect to the cerebellum, and that's called the inferior cerebellar peduncles there. That connects, all right, the medulla oblongata to the cerebellum. So what do we find in the cerebellum? Well, we're going to find a lot of autonomic nuclei. I like to call them control centers, right? So they play a role. The autonomic nuclei has to do with the autonomic nervous system, right? With sympathetic and parasympathetic. So you'll see here, we got a couple: cardiac center, vasomotor center, medullary respiratory center, and several others. Look at all these other nuclei, okay, that have functions here in the brainstem: coughing, sneezing, vomiting, salivation, swallowing, right? Some of those have to do with digestion, right? Cardiac center, you'll learn more about this when you study chapter 19 and 211. Your heart's output, whether your heart's beating fast, whether it's beating slow, whether it's beating stronger or not as strong. Okay, the cardiac center is going to regulate all that. The vasomotor center has to do with blood vessels, and specifically how dilated the blood vessels are. Okay, so that's what when we talk about regulates the blood vessel diameter, whether if it's really big or really small. Because if you have a big diameter for a blood vessel, that means a lot of blood can flow through that blood vessel. If you have a really small diameter for the blood vessel, okay, that means not as much blood is going to flow through that. And so this area here is going to regulate how big or how small your blood vessels are, which will then influence your blood pressure. This is usually when I write an equation on the board. You don't have to know it for this class, but it's just good to know because it'll help you when you take 211, right? BP, blood pressure, is equal to heart rate times TPR, which stands for total peripheral resistance. Basically what that means is if your blood vessels are really small, if they've contracted down and the lumen is really small, the opening where the blood goes through, if the diameter is really small, you increase the resistance. It's harder to get blood to flow through a really small opening compared to a really big opening. And so if you increase the total peripheral resistance, you're going to decrease the diameter of the blood vessel. And that's what we're talking about with the vasomotor center here. All right, then we got the medullary respiratory center. Breathing rate, how fast or how slow. You have two parts to this. You've got a front group and a back group, or a dorsal and the ventral group. You'll learn about what they do, okay, when you study chapter 23 and 211. All right, and then we have all those other nuclei for those different reflexes. Coughing, sneezing, right? You inhale something, right? We've all done it. When you inhaled something like pollen or whatever, and you start to cough or sneeze, that's because your body's trying to get rid of it, try to get it out of the respiratory tract. It does not want you to inhale it down into the alveoli of your lungs, right? Salivating. You smell something good, you start to salivate because you're getting your digestive system ready to maybe eat. Okay, your stomach might start to growl because the muscles in your stomach are starting to turn on and mix the secretions that your stomach is starting to make, right, in preparation for you to ingest something there. Okay, so in the medulla oblongata, we're going to see more of our cranial nerve nuclei. So you're going to see some nuclei from cranial nerve 8, vestibular cochlear, glossopharyngeal, which is cranial nerve 9, vagus, cranial nerve 10, accessory, which is cranial nerve 11, and hypoglossal, which is cranial nerve 12. So we're going to see the nuclei, all right, for those cranial nerves in those locations. I'm going to mention this now because we're going to be talking about it later on in chapter 14, the nucleus cuneatus and the nucleus gracilis. Right? Those two structures are going to sit in the posterior portion there of the medulla oblongata, and they're going to receive somatic sensory information. Things like vibration, okay? That is one of the sensations that is going to travel, right, to these two structures here. So when you feel something vibrate, like your cell phone, okay? If you have your cell phone in your back pocket and it's on silent and it starts to vibrate, that sensation is going to travel from your sensory nerves, okay, from that area where your cell phone was. It's going to travel, right, into your spinal cord, travel up the posterior white columns. Y'all remember the dorsal white columns? We just labeled those today in lab. Right, it's going to travel up through that region, and then it's going to wind up into the nucleus cuneatus and the nucleus gracilis. And then that's when you get that, oh, I feel something, okay? And it's going to travel up through this structure here, the medial lemniscus. all the way to the thalamus. Because remember, you do not have any conscious recollection or knowledge of a sensation or of a sensory stimulus until it gets to the thalamus and it moves past the thalamus. If that sensory information makes it to your spinal cord, but never makes it out of your spinal cord and never made it to the thalamus, and you have no idea what's happening. You wouldn't know that your cell phone's vibrating. Now it depends, because sometimes with that is the nerves can have just random action potentials traveling through. You see it more commonly with people that are dehydrated because there's an electrolyte imbalance. But we'll talk about phantom limb pain. Yeah, we'll get to that too. All right, so here you can see, right, there's the medulla oblongata. All right, and you'll have all these different structures that we'll talk more in detail, but there's that medial lemniscus. So that's going to transfer or carry that sensory input information for things like vibration. All right, let's talk about the last region of the brain, and that is the cerebellum. Okay, the cerebrum is the largest, and the cerebellum is the second largest here. So very similarly to what we saw with the cerebrum, you're going to see with the cerebellum, or little brain. Okay, you had gyri in the cerebellum, in the cerebrum. You're going to see these structures here called folia, which means folds. So they're kind of like mini gyri. But you're still going to have, all right, some sulci or sulcuses in between there. So much like the cerebrum, the cerebellum has two hemispheres. Remember, the cerebrum had the right cerebral hemisphere and the left cerebral hemisphere. Well, the cerebellum, same thing. It's got a right cerebellar hemisphere and a left cerebellar hemisphere. And they're connected to each other through this structure here called the vermis. All right, that's right in between those two hemispheres there. And so it is going to, in this area, receive sensory input information primarily from a lot of the structures in your torso, but it also plays a role in balance. Balance is not the same thing as proprioception. We all know what balance is, all right? We're all able to maintain our balance because we're not falling out of our chairs right now. Part of that has to do with proprioception. But the two things that contribute to what we call balance is your vestibular system, equilibrium, and then also what I was talking about before, proprioception. And we'll get into more details about that as we move through the course here. All right, so in the cerebellum, the outer part of the cerebellum, okay, is going to be made up of gray matter. We saw that same thing with the cerebrum there. So that's going to be our cerebellar cortex. The white matter on the inside, that's that tree of life we labeled, the arbor vitae, right? And we're also going to see, right, nuclei located inside, okay? And nuclei are going to be gray matter because what's a nuclei? It's a cluster of cell bodies. Cell bodies are not myelinated, so they will not be white. They will be gray, okay? Cell bodies aren't myelinated. The dendrites aren't myelinated. All those have to do with that structure there. Again, this is just showing you, all right, in our cerebellum, you've got the three connections to the brainstem. So the superior cerebellar peduncle attaches to the midbrain. The middle cerebellar peduncle goes to the pons. And then finally, the inferior cerebellar peduncle goes to the medulla oblongata. So each part of your midbrain has a direct connection to the cerebellum, right? And when we talk more here in a few moments about the cerebellum, you're going to see why. Because you're going to be getting sensory input information going into the cerebellum, but then you're going to be getting motor output information coming out of there to help with fine motor movements. It likes to help you correct. If I were to hold something up in front of you, I'm like, hey, just grab this thing, and you go like this, you start to go off, your cerebellum will be like, no, go to the left, and then it can help you grab it. It helps you with certain movements there, okay? All right. So let's talk about some of those physiological functions there. This is why I tell folks, consider the cerebellum the place that we start to fine-tune our movements here. Right, so you're going to see after a while, right, you get better at certain dexterity type of movements, for example. And I know I used the example of like playing the piano. You get better at playing the piano, right? One, because you're learning how, right? But your ability, or juggling, like use juggling. Certain things when you first started, if you played sports, same thing. If you're practicing trying to take a jump shot, or if you're trying to learn how to kick a ball, right? The cerebellum helps this because it is going to create, right, these corrective patterns here. And so it's going to take what you've previously learned, right, and then it's going to extrapolate it. Has anyone ever heard of practice makes perfect? Yeah, I'm sure most of you have. Well, I don't like that because you could learn how to do something perfectly wrong, right? So imagine that. You start to learn a skill, but let's just say you're doing it wrong. Right? But you're really good at doing it wrong because you kept practicing it and you kept reinforcing it. All right. So I believe in perfect practice makes perfect. You know, if you learn how to do it correct and then you keep reinforcing that and keep practicing those correct movements, then you're going to build. A lot of people have heard probably muscle memory. You guys heard of that? Yeah. So you'll hear terms like muscle memory. That's what the cerebellum does. It is going to, all right, store these movement patterns. And as you improve upon it and make corrective movements to that, it will help you, right, cause both voluntary and involuntary, but it helps to eventually get to that correct movement pattern that you wanted to get to from those memorized or those learned movements here. And so that's what the cerebellum does. It just kind of tweaks things a little bit, right? As you're, like I said, when I ask you to grab something, right, as you're starting to come from a distance, you're making movements to grab whatever that is, right? You don't think about it now because we're all pretty good at that kind of things. But watch a little baby try to, it's all over the place. You're like, here, kid, grab that, you know? I was really proud of my son when he had a pretty good grasp because I used to have him pick stuff off the floor for me. And I would hold him by his foot and I wouldn't bend over. I would just hold him upside down and he'd reach out and grab stuff off the floor and he'd pick it up. It was the best. He loved it. He thought it was a game. I used to grab him by his feet. We'd go and just pick stuff off the floor. But he learned how to do that because his cerebellum was helping him make those corrective movements there. So here, when we talk about, all right, our balance per se, our equilibrium and posture, right, the cerebellum helps play a role in that because it's going to receive that proprioceptive input information from your muscles, from your joints, all right, telling you where they are in space around your body. So you can make those corrective movements here. I'm going to show you a picture here, right, in a second here. But we're going to talk about what we call these motor plans and how it affects our sensory feedback, which is essentially what I refer to as an error correcting signal. So let me show you. This slide up here is showing you, okay, when you decide to do something, all right, write a letter, type on your computer, the origination of those thoughts, all right, those motor commands comes from the primary motor cortex, which is located right here in the precentral gyrus. And also don't forget about the prefrontal motor cortex there, which is the association area that helps store motor memory. So you have that information. It starts to come from the frontal lobe. And so it goes down, all right, through your brain, down into the spinal cord, and out to the effectors. So whatever it's going to be. So you start to, let's say, handwrite something, okay? And it's starting off a little bit sloppy, okay? Well, then you have the proprioceptors and the other sensory receptors in the muscles that you are utilizing to do whatever activity it is that you're doing. And it's going to send that motor input information, or excuse me, that sensory input information up through the spinal cord, right? Into, some of it's going to go here into the cerebellum here, because the cerebellum is going to tweak some of those movements there, and then it will send some of that information, that corrective feedback information, up into the primary motor cortex. So maybe you're not activating enough motor units, for example. Maybe we need to activate more, right? And so then, right, we're going to correct that information, and then the same thing, the voluntary movements will descend back down to those effectors there. And so it's this kind of loop-like process, but information, that sensory input information is coming from those effectors. The cerebellum is going to kind of mull it over and analyze it, and then it sends its corrective feedback instructions up to the primary motor cortex, like, hey, you need to start activating these motor units and not those motor units. And so anyways, it's this whole process, and that's basically how the cerebellum, right, is going to be able to fine tune a lot of those movements there. So first clinical view of the day, effects of alcohol and drugs on the cerebellum. So I know no one in this room has ever been pulled over and had to do a roadside sobriety test, but these roadside sobriety tests are literally cerebellar medical evaluation tests. So when they ask you to walk the line, they're testing for what we call ataxia, right? The inability to keep your balance there, right? They'll ask you to do this thing where you put your finger up. When I say they, I'm talking about a doctor. I'm not talking about the cops, all right? But, all right, they'll put their finger up. And so they'll ask you, all right, here's what you're going to do. You're going to touch your nose and then touch my finger. And so then go and touch your nose, and then they move their finger. So you're doing this kind of thing. Or when they ask you to put your arms out to your sides like this, close your eyes, touch your nose. Okay, that's going to be, right, the cerebellum. And so they're essentially the police officers, because the cerebellum is one of the first areas that gets affected through alcohol intoxication and certain drugs. So they're essentially testing your cerebellum there. Okay. All right, that's it for the regions of the brain. Now we're going to just talk about some other structures in the brain here. The first one here is the limbic system. Okay, this is the emotional part of your brain. So fear and anger, all right, all these various emotions here are going to be located in the limbic system. And the interesting part about the limbic system is it includes, all right, several regions. All right, you're going to see several areas in the cerebrum and in the diencephalon that are going to be involved in, okay, the limbic system. So let's just talk about a few of these structures here. You've got the cingulate gyrus, the perihippocampal gyrus, the hippocampus, right, the amygdaloid body. Look at all that stuff from the olfactory system, olfactory bulbs, olfactory tracts, olfactory cortex, and the fornix. Right, so these are just some of the structures here in the limbic system that are going to be, all right, involved in emotional responses. So the cingulate gyrus is right above your corpus callosum here. And again, it is going to help move sensory information throughout the limbic system. All right, then we have the perihippocampal gyrus, and this is located down in the temporal lobe. I'll show you pictures for all this stuff. Then we have the hippocampus. Right, now this thing here, you want to make sure that you highlight. The hippocampus helps to form long-term memories. If you damage the hippocampus, you cannot form long-term memories anymore. Whatever memories that you have, but from that point on. So if I leave here today and I hit my head really bad and I damage my hippocampus, I'll know everything up until this point. I'll know all of you, all right? But my next semester class, it would be like it'd be like a reintroduction every time I met them. Okay, I'd have all my information up into that point. So your hippocampus helps you to form long-term memories there. And we'll talk about short-term and long-term memories here in a few moments. All right, the amygdaloid body. This also plays a role in memories, but it plays a huge role in certain emotions like fear. So people that lesion the amygdaloid body, for whatever reason, they start to, and they don't know why, but they'll start to want to engage in really weird, erratic sexual behavior. I don't understand why, but also they will act, right, irrationally sometimes, right? Because that fear emotion there, right? But again, here in the amygdaloid body, you're going to store emotional memories there. So if you've ever, and I think I used this example before when I was talking about the hypothalamus there, where you, no, not the hypothalamus, excuse me, the epithalamus, the habenular nuclei. When you're driving along and you smell something, food, some food, and it reminds you of your uncle's family reunion barbecue or whatever, and you get emotional or whatever. That's this. All right. So the limbic system has a connection, all right, to your olfactory system. So when you do smell something, all right, either good or bad, maybe it was you had a bad, I'm better now, but my very first experience with collard greens was a very bad experience. And I so badly want to love collard greens. But when I was a freshman at the Citadel, I made the mistake of asking for seconds for food at dinner, or was it lunch? Anyways. And so the upperclassmen thought it'd be funny. They gave me a bowl of collard greens and they poured in hot sauce and vinegar and anything else that they could pour into that to make it disgusting. And they said I wasn't allowed to leave the table until I ate it all. So I ate it all. And for a long period of time, I could not smell or eat collard greens until there was a restaurant called Bacon Brothers. It's no longer around. It was on Pelham Road. And we were out with some family. This is 5-6 years ago. And they ordered collard greens and they looked so good. They smelled even better. I was like, I'm going to try it. And at first, though, I was having an emotional response, like, oh, like kind of disgust. I was like, because of that memory. But my taste buds took over and they were awesome. So I always recommend it. If anyone likes collard greens, well, the restaurant's not there anymore, so it doesn't matter. All right. And then we have our fornix. And just think of the fornix as the structure that helps to connect various parts, all right, of the limbic system to the hippocampus. Right? It's this nice, you can see all the list of all these other structures here. And again, I'm not going to require you to know that, but again, you have tons of structures that the fornix is going to connect, all right, the hippocampus to. So when you look at the picture here, here's the limbic system. All of these structures here, except for like the corpus callosum and like the thalamus here. But you've got the cingulate gyrus here. You can see the hippocampus and the perihippocampus gyrus here. All of these structures, all of these various things are part of your emotional brain, right? So keep that in mind. All right, reticular formation. I talked about this when we were going over the brainstem, when we were talking about the midbrain and the pons and whatnot. So first of all, the reticular formation is gray matter. And so it has two parts, a sensory part and a motor part. This is the one I was telling you, the motor part has to do with muscle tone. So like when you're very relaxed, okay, the motor component of the reticular formation is going to cause your muscles to relax. Like when you're sleeping. This is what I was telling you, right? When you're standing versus sitting versus laying down versus sleeping versus being awake. When you're sleeping, okay, your motor tone decreases significantly because the reticular formation here, all right, is not going to be very active. Now, the sensory component has the reticular activating system, otherwise known as the RAS here, right? And so this part is going to take, right, stimuli information, maybe in this room, okay, wherever, and it's going to send it and process it through your sensory apparatus. So this is where I was telling you, when you're awake, you're going to have more sensory input information traveling through here. So your alert levels should be higher. But when you're sleeping, your alert levels are much lower. But what happens when the alarm clock goes off? I mean, for the most part, you get your alert level increases a little bit. And that's because of the sensory component here. All right. So keep that in mind. All right. Second clinical view, pathological states of unconsciousness. All right, so you can see that there are 4 types, and they go from mild to more severe. So like fainting, all right? Brief loss of consciousness could be from oxygen deprivation, most commonly, right? And so you'll pass out momentarily. And usually you'll come to, right? But it is a very short, hence brief loss of consciousness here. All right, stupor, you may have experienced some sort of physical trauma, all right, maybe to your skull here. So this is the one where you've seen in movies, like someone's kind of out of it and they take like a salt or a smelling pack and they put it under their nose and they're like, oh yeah, they come to. That's what we're talking about. So when you're in a state of stupor, some sort of extreme stimuli, like if you have to clap your hands really loud to get somebody out of it if they've been in like a boxing match and they get knocked unconscious or whatnot, right? A lot of times it's going to be from some sort of head injury. Okay, if you look here, some of the other causes. Well, I'm in the wrong one. Sorry. Head injury, but metabolic disorders, right? Malnutrition can cause this, right? Liver, kidney disease, especially the kidneys are responsible for filtering your blood. And so if they're damaged and they're not filtering your blood, you're going to get an increase in toxic levels of certain types of material in your blood. And so if it gets pretty high, it can put you into a state of stupor. Always think drug use, of course, right? Coma, deep and profound unconsciousness. This is when you are non-responsive, and you've seen, right, in movies or soap operas where somebody's lying in bed, and they're seeing the brain activity going on the computer screen there, but yet they're not coming out of it. So this one again is going to be, and sometimes you can get a medically induced coma, right, where it's actually better to put somebody into a coma, right, because it helps with the healing process. Those are extreme situations, but you can, same thing, head injury, metabolic failure, right, cerebral vascular accident, very low blood sugar for those folks that are diabetic, right? You've heard of diabetic coma. When their blood sugar levels drop so significantly, they're at risk for that. And of course, always drugs. I mean, that's usually most of the time when you come upon somebody that's unconscious, one of the things you should be thinking of initially is drug use. All right. I'm not saying always, but I mean, you should consider that. All right. And then finally, the persistent vegetative state. This is the one where the person is, quote unquote, brain dead, right? Yeah. Their brain is active enough to keep their vital organs operating, but that's it, right? There's no conscious thoughts or anything in these folks here, all right? You might see maybe a muscle twitch here and there, but again, that's the reticular formation, all right? And sometimes you'll get spontaneous action potential discharges that are causing, all right, some of those movements to occur. All right, I want to kind of circle back now. We talked about the cerebellum initially in this class, and we talked about the higher order brain functions, and I want to talk about what some of those are. Right? So for example, we got our higher order brain functions here, learning, memory, and reasoning. All of these are going to occur in the cerebrum here. And so here's the thing, right? Most of these occur when we're conscious, right? But we're going to see some occur when we're unconscious. And this is kind of going to lead me into sleep, the importance of sleep, because when you're sleeping, that's when you transition a lot of short-term memory into long-term memory. And I'll talk about that here in a second. How about if I talk about it right now? All right, let's talk about sleeping. All right, so notice how it's described here, a natural temporary absence of consciousness. Yes, it is natural, right? Sleeping is vital here. So what you're going to see is, just like with anything, if you ever notice your electric bill, okay, some of these thermostats will even show you that you have more activity during the daylight hours, and your body's like that. So when you're awake, more activity is going on. When you're sleeping, less activity is going on. So most of the time, my electric bill is high during the day. At night, not so much. Why? No one's on the internet. Hopefully, they're in bed. All right. Lights are shut off. All right. Same type of scenario happens here with sleep. Okay. When you are sleeping, we're starting to shut certain things down, and your frontal lobe won't be as active, right? Because you are essentially unconscious in that sleep-like state. So we use, all right, an EEG, right, an electrical encephalogram, right, to actually monitor your brain waves. And they'll also monitor, if you've ever had a sleep study done. Has anyone ever had a sleep study done? Okay, so you probably know. And in a lot of times for sleep studies, I'm not saying that's why you had to have it, but it could be for sleep apnea, or if you're having difficulty sleeping, if you're an insomniac. I mean, there's tons of different causes for that. So what we've seen with sleep, you have two parts to sleep. You have REM, which means rapid eye movement, and then you have the non-REM sleep. Right? You spend most of your time in non-REM, okay, 75%. Right? And so when you are sleeping, you are going to engage in, this is why I always tell, you ever wonder why a baby sleeps so much? Okay, a newborn baby can sleep 18, 20 hours a day, because what's it doing? Well, it's growing. Okay, remember we talked about in lab today, right? Their nerves are myelinating. That takes work, right? So, anyways, in sleep, right, in your non-REM, you're going to see growth, rest, energy conservation. What does that mean? We're going to, one, not be using a lot of energy or stored energy like ATP, excuse me, because we're not doing any activity. But if we've depleted any of our ATP stores, we're going to replenish them during this period of time here, right? When we have our REM sleep, the rapid eye movement, this is the one where you literally see the eyes kind of darting back and forth. Much shorter period of time. This is where you do what we refer to as memorable dreaming. Okay. So when you have memorable dreaming, like the words or the term says, you will remember your dreams. Not all of them. Every once in a while, I can remember some of my dreams. All right. Although whenever I ask my son or my daughter, I can't remember which, if they have dreams, they're like, I can't remember my dreams. So it makes me wonder, one, get your butt to bed, all right, and sleep more, because then you'll have more of a chance to be in REM sleep here. But this is the most important part about REM sleep is this last one. This should be the first one. This is when you get what we call consolidation of memories. This is what I was telling you about. This is where we're going to transition short-term memory into long-term memory. This is where you will transition when you're studying all of this information, okay, and you get a good night's rest, it will then go into your long-term memory. So when you have to recall that information, i.e. on a test, right, it'll be there for you. This is why I'm always very, very, and I know it's easy for me to say because I'm not in your shoes, but I was once in your shoes. I never slept when I was in college, only because I was up studying my butt off all the time. But teachers would always say, get a good night's sleep before the test, get a good night's sleep before the test. This is why. This is why. So you can get that memory consolidation going on. Right. So babies, infants usually sleep 17 to 18 hours. Teens, I always feel like this is too short, but all right, anywhere between 8.5 to 9.5. In adults, 7 to 8 hours. I was told that an Olympic athlete sleeps about 8 hours. That's an Olympic athlete. I'm not even close to that. So I'm happy if I'm getting 6 or 7. Okay. So like it does say up there, lack of sleep is unhealthy. It will lead to poor memory, but here's the big thing. Poor immune function. Poor immune function. That's a problem, okay? Again, when you're sleeping, that's when your body is recovering. That's when your body's healing, right? And so if you're not giving your body enough time to do that, you're wearing yourself down. And so your immune system, and we'll talk more about that when we get into chapter 23, not 23, 22, when you're in 211, we'll talk a little bit more about that then. All right, insomnia. This is where you can't fall asleep or stay asleep. This is very true. The older you get, ask any, I say, senior citizen, elderly person, they don't sleep as long as they used to, right? Well, one is that they're done growing, so it's not like that's going on, but they're unable to sleep as well, so you'll hear them complain more about insomnia. All right, sleep apnea. This is, all right, yes, it's mainly affiliated with breathing, either stopping breathing sometimes, all right, or just really erratic breathing here. But I'm not lying. If you know anybody with sleep apnea, or you suspect that has sleep apnea and they haven't gone to get a sleep study done, or if they need a CPAP, it literally will take years off their life. It really will. I had an uncle. I shouldn't say had. I still have him. Go ahead.
I didn't know what was wrong with me, but I was falling asleep during the day. Like I would fall asleep standing up. My days off, I take like 3 or 4 naps. I had my sleep study, and the next day I stayed up 15 hours and totally shocked. The machine, like CPAP machine, saved my life.
Yeah, I'm telling you, the CPAP. Yeah, I mean, they got the CPAP, and the CPAP, as you can see there, continuous positive airway pressure. What does that mean? A lot of times when people are sleeping with sleep apnea, they'll stop sleeping. Excuse me, stop sleeping. They'll stop breathing. All right. And then they'll start themselves again. I mean, I was reading this article, and this lady was saying how she would go and visit her grandmother in the summertime and sleep in the same room with her grandmother. And she would lay there in bed and she would listen to her grandmother just take a breath in and then exhale and then nothing. And she would time it and she would count. She'd get up to like 30 seconds, 45 seconds. And this lady's not taking a breath in. And it was freaking her out. Anyways, so some people, an early sign for sleep apnea is really loud snoring. And it just can be, you know, the airway there is not big enough. So when I do my DOT medical exams, I have to measure the opening to the esophagus, the pharynx there. And people with smaller throats will have a smaller open. It doesn't mean they'll have sleep apnea, but again, there's certain things that you want to look into. But again, my PSA is done, but sleep apnea is something you don't want to mess with. Okay, cognition, higher order function. Right, so what is the definition of it? Right, mental processes of awareness, knowledge, memory, perception, and thinking. So that's what we're talking about. When we talk about cognitive or cognition, we're referring to all of these various, all right, different topics here. And so we're going to see, all right, in the cerebrum, we already discussed this in last class, we're going to have all of these different functions here, awareness, knowledge, memory, they're all over the place, all right? These association areas can be in several different locations in the cerebrum here. And so, like, for example, you'll see up here in the frontal lobe, this is where you're going to have your personality is going to be located. Decision-making, cognition, learning, right? So has anyone here taken a psychology course? Does anyone here know who Phineas Gage is? You know when I say this, did you guys ever study somebody that had a metal pole go through their skull? That's Phineas Gage. So Phineas Gage was a railroad worker, very nice, very, very nice man, very even-tempered. Well, anyways, he was working on the railroad. I can't remember if his job was to pound the spike into the rock and then stick the dynamite in there. But anyways, something happened. A railroad spike shot through his skull. I think it went under his left eye and came out the top of his head. He lived after that, all right? But it tore through and went through his frontal lobe there, especially the area where his personality was. So he went from being a kind man to an irrational, fly off the handle type of guy here because, right, that area was damaged there. So when we talk about the frontal lobe, we're going to see personality, planning, decision-making there. Anytime you damage any of those areas there, you can have altered effects to that or decision-making. Again, this kind of leads back to what I was saying. That area hasn't fully developed until you're about 25 years old, right? So one of the reasons why we don't let kids drive at age 10, all right? Well, some do on the farm, but anyways. Same thing here when we're talking about with our the sensory aspect here, right? Primary somatosensory cortex here. If you damage that area, okay, on one side of the brain, you won't be able to get sensations from the opposite side of the body. So if you damage your right primary somatosensory cortex, then the left side of your body, you won't be able to feel like pain, for example, which in some cases might be nice, I don't know, or temperature or like vibrations or any of those. So when we talk about the ability, when you lose the ability, okay, to recognize a sensation or a stimuli, we call that agnosia or agnosia, right? So the example that's given here, right? A lesion in the temporal lobe may lead to the inability to recognize the meaning of sounds or words. Because remember, your temporal lobe has to do with hearing, right? And so if you damage that temporal lobe area there, you will lose that ability for agnosia. Like speaking, if you were to damage your Wernicke's area, which is that speech comprehension I was telling you about, you could hear what I was saying, but you just wouldn't understand what I was saying, all right? So I think I got some examples here we'll talk about here if we have time at the end of class. This is one of the ones I really like to talk about is the memory part. All right. So there's different types of memory. You've got sensory memory, short-term memory, and long-term memory. You hear about the latter two a lot of the time, short-term versus long-term, all right? But sensory memory just has to do with, all right, associations when you have any type of sensory input. Okay, you touch something, you hear something, right? It only lasts for a few moments. Okay, but that's our sensory memory. And then sensory memory will transition into short-term memory. And short-term memory, all right, a little bit longer, all right, but it has a limited capacity. Now, there are certain professors that recommend, if you're trying to memorize something, only memorize 7 things at a time. For example, like we did some labeling today, okay? We labeled way more than 7 structures. But what usually is recommended for some folks is just learn, if you're going to sit down like, all right, I want to start to study for the second lab exam, and I'm going to pull out the Quizlets there. Only do 7 at a time, okay? Then give yourself a little bit of time, put it down, come back like an hour later, and then test yourself. See if you know those 7 things. If not, then it's because you haven't transitioned some of that information into long-term memory here. Right? So short-term memory does not last very long. You can see here, seconds to hours. It's a brief duration there. So, but the goal is you want to try to get stuff from short-term memory into long-term memory. In order to do that, you are going to engage in this process here called encoding. Right? Encoding is when we move something from short-term memory into long-term memory. I'm going to come right back to this slide, I promise you. I love this slide here. This is a good one. So here's your stimulus, right? You have all of your sensory organs, whether it's touch, taste, sight, hearing, whatever, smell, right? And so the stimulus occurs, whatever that stimulus may be. So you're going to first experience that stimulus through that sensory memory there, only for a brief period of time, very short. All right, so if you're actually paying attention to it, you smell something, all right, you make a note to yourself, I smell something that's good. All right, it's going to move into that short-term memory, and that can be there for minutes to hours. Now, if you keep thinking about it, or if you keep smelling it, all right, it's going to keep going through this repetition period here. And then if you do it enough times, you're going to engage in encoding, which means you're going to transition whatever that memory is from that short-term memory into the long-term memory. And once it's in the long-term memory, it could stay there forever, okay? Thing is, every once in a while, you've got to retrieve that information, like when you're taking a test, all right? So that's where retrieval comes from, right? So if you put it into long-term memory, you ever heard the saying, if you don't use it, you lose it, that sort of thing? So if you're not retrieving it, you could actually forget it. So it just moves out of your long-term memory and it's gone, all right? But if you retrieve it, it goes back into short-term memory, then you think about it or do whatever, then you encode it and you put it back into long-term memory. So you have this cycle here. And you notice though, repetition, that's the important part. More times you repeat something, then you can get it from that short-term memory, engage in encoding, and get it into that long-term memory there. So that's what we're looking for here. We want to get it from short-term, as long as we're able to repeat it as much as you can. That's why I always tell folks, right? Look over like Quizlets, right? A couple times through the day, but look over 7 of them and see if you can, if it makes it easier. If it doesn't work for you, it doesn't work for you. Some people, if it does work, but for others, it might not be. All right, so this is where, right, I was telling you about the hippocampus. Right, so encoding requires both the amygdala, remember that the emotional memories formation here in the amygdala, and then the hippocampus. It's easier to form certain memories if you're associating certain emotions with them. Whether it's fear, okay? But think about it. Kid does something, I say a kid, your child does something that you don't want them to do. Say they run out into traffic, right? What do you see a lot of parents do? Grab the kid, smack him on the butt a couple times. Oh, you run out into traffic, all right? And the kid cries, okay? So the kid was upset, fearful, but that fear stimulated the amygdala, which helped the encoding process, as you better believe, because that's happened to me when I was a kid. I ran out in practice and my mom paddled me. Never ran out into traffic again because I was worried that she was gonna give me a paddling. And so that fear that emotion made a good memory, so I didn't do that. All right. I'm not saying that's how you have to do it with all kids. All right. But worked for me. Okay. So that's what LTM stands for, long-term memory. Okay. Is housed in, all right. What this statement here says, long-term memory is housed primarily in the appropriate association cortex. So that means visual memories get stored back in the occipital cortex. Hearing memories get stored in the temporal lobe. That's what we're talking about. Motor memories will be stored in the premotor cortex. All right. So you have certain areas for certain types of memories. And so when you go through that encoding process, that's where you're going to lock it into. You're going to lock it into those specific areas there, which brings us to our third clinical view of the day, Alzheimer's disease. All right. There's a movie called The Long Goodbye. I've never seen it. Has anyone here ever seen The Long Goodbye? Yeah, I think it's an old movie. But anyways, all right. I've heard this recently that Alzheimer's disease, has anyone ever heard of that Alzheimer's is the diabetes type 3? Has anyone ever heard that? Okay, yeah. It's interesting. Not like, and again, I don't, because I'm not going to get into the time because it'll take a long time to explain what I just said. But they are saying that some of the causes of Alzheimer's, okay, that there are certain dietary components that can lead to the cause here. Now, let me show you what I'm talking about. Now, basically, we still aren't 100% sure as to the cause of Alzheimer's. It's said to be idiopathic. When I was in med school, the most common theory or the forefront theory was this one right here. These beta amyloid plaques, which are protein plaques that would get deposited in the neurological tissues of your brain. And so it was theorized that these beta amyloid plaques called tau tangles there, right, is going to be the cause of Alzheimer's. Still up in the air. I haven't seen anything conclusive. And there was a study that I read last year that they're starting to think that certain antibiotics can help treat Alzheimer's. So, but again, we're still out on that. But where do we see, or who do we see Alzheimer's in? Older folks. Okay. And so a lot of times these folks might just display dementia-like behaviors. They forget things. It could be your grandma or your grandfather, and they might forget your name or confuse you with somebody else in the family, right? Not saying that anytime an older person does that they have Alzheimer's, right? But that is a dementia-like symptom. Forgetting things, all right? Mood swings later on, falling in some cases. But what we'll see is, one, it is a slow and progressive loss of some of their higher order functions. And what are the higher order functions? Personality changes, okay? Memory, okay? Knowledge, that sort of thing. Decision making. They might not be making very good decisions. They could snap at you, all right? So this is what we're kind of looking at. And one of the things they've seen is, and this is another theory, loss of smell may be an early sign. I don't know why. And then someone asked me this too, and I cannot remember what the scent was. Someone was asking me if a certain scent was a starting indication. I wish I could remember what the scent was, but that's what they do believe as one of the causes here. And we'll finish up here with the last clinical view here called amnesia. All right. Partial or complete loss of memory. Right. And so again, this is what I was kind of telling you, where if I had damaged a certain area of my brain, I wouldn't be able to create new long-term memories. All my old long-term memories would stay. Now, two types or causes here, right? Psychological trauma, see it all the time in abuse victims, okay? Whether it's physical, sexual, right? Or a direct brain trauma, right? And depending on the size of the psychological trauma or the actual physical trauma that occurred will determine the extent of the amnesia. You can have what we call retrograde amnesia or anterograde amnesia. Retrograde amnesia is where you see in a movie or a TV where someone bangs their head and they forget who they are. Has anyone ever seen the movie Overboard with Goldie Hawn and I think, I was gonna say Kirk Douglas, but anyways. So retrograde amnesia is when you forget your past. Anterograde amnesia is when you can't make any new memories, but you can remember everything from the past, right? So it depends on damage to these certain structures, but especially, I told you, with the hippocampus here, if you damage the hippocampus, you are not going to make new memories there. Oops, I went the wrong way. All right, let's call it quits. Folks have done great. I will send out a video because there's only a few more slides here.